Hello, everyone. Welcome to the FH Europe Foundation Rare Disease Day webinar. This year, our theme is More Than You Can Imagine, Rare Disease Day through the lens of HoFH and FCS, a rare lipid conditions. With the help of our experts, medical professionals, and patient advocates, we'll explore the similarities and differences in living with these two conditions, familial chylomicronemia and homozygous hypercholesterolemia. While this is a patient support group, we also warmly welcome healthcare professionals from all around the world. So warmly welcome. The session is being recorded and will be doing a bit of housekeeping. The session will be recorded and the recording will be available at FH Europe Foundation's YouTube channel. We are planning to do an interactive section at the very end of this webinar, so please stay tuned for Q&A session. As a friendly reminder, please do not share any personal or medical records during this webinar. So let's get started. For the first of all, I would like to welcome everyone. I'm Maja Bartoszewicz-Moritz, and recently I have taken a role as the project manager for FH Europe Foundation. I would love to introduce our experts, starting from our patient experts, patient ambassadors. I would love to welcome Finian Day-Lewis, Maria Nassif, Marwa Sadiq, and Helga Davidson. It's my pleasure also to invite to our discussion Professor Antonio Gallo. And starting with that, dividing in 4 sections of questions, I would love to give the floor to Professor Antonio Gallo to start introduction about our More Than We Can Imagine. Professor Antonio, the floor is yours.
Thank you very much, Maya, and good afternoon, everyone. So it's an honor for me to be attending this webinar, and the idea is just to go for an overlook of these two diseases with this quite challenging question that has been asked me: what is common and what is different between FCS and HoFH? So imagining that we are among patients that live with one of the two conditions, I was thinking that maybe the other condition might not be familiar to at least half of you. So I'm just going to start with a quick overlook of what is HoFH and what is FCS. As you can see here, HoFH is the homozygous familial hypercholesterolemia, is an extremely rare disease which involves one patient over 300,000 to 1 million, that is characterized by extremely high levels of LDL cholesterol, about 5 times more than a person from the general population. This high cholesterol level is present still already since birth, and also might reflect into the deposit of this cholesterol in the skin, in tendons, which results into the formation of this cutaneous or tendon xanthoma, which you can see on the pictures on the left. This exceeding LDL cholesterol levels are not present in the parents of the patients, who also carry, of course, a mutation. So the patient has been inheriting 2 copies with a defective function on the LDL cholesterol metabolism that are carried by the parents. Both parents have a hypercholesterolemia, but this hypercholesterolemia is much milder. These increased levels of LDL cholesterol are associated with an increased risk of coronary heart disease, of heart attack. And for this disease, it's fundamental to have an early start of treatments with statins, ezetimibe, often LDL apheresis, and then other new treatments that may allow to reach the lowest LDL cholesterol possible, because lowering the exposure to this very high LDL cholesterol levels will reduce the exposure to the cardiovascular risk in this condition. On the other side, we have the familiar chylomicronemia syndrome, which is another extremely rare disease. Here we are talking about, once again, one patient over 1 million. And this time, since birth, we have very high triglycerides levels. Triglycerides are still lipids, it's not cholesterol, so it's a little bit different. We can have some temporary deposits on the skin that we call some eruptive xanthomas, but these are not permanent and are quite are not necessarily found in every patient. It is a autosomal recessive disease. What does it mean? It means that the parents that once again give the two defective copies to the patient do not express the disease. So they don't have a significant hyperchylomicronemia. Patients with FCS do not have an increased risk of cardiovascular disease, but due to the increased viscosity of the blood, which is very thick, you can see in the figure up on the right that it looks like milk, the plasma, when there are too many triglycerides in the circulation. This increased thickness of the blood results in an increased risk of acute pancreatitis. So it's a disease that depends on the diet and that constrains patients to live with a low-fat diet. It's not a matter of eating only good fats, it's just a matter of not eating fat almost at all. Up to now, the therapies for this disease have not been sufficient, but also in this disease, we have some emerging therapies that are very promising in terms of reduction of triglycerides levels and also in the reduction of the risk of complications. So, based on what I've been saying already, we can see that there are some differences between the two diseases. The fact that we are facing a recessive disease for FCS makes it sometimes a bit of a lonelier journey for the patient because the diagnosis might be really delayed in a very significant way. The complications of the two diseases are of course different because what you can see here is that when we have a lot of chylomicrons in FCS, we don't have the risk that these particles might infiltrate the arterial wall, but they might damage the pancreas and so might be responsible for this acute pancreatitis. On the other side, no risk of acute pancreatitis for HoFH patients, but an increased risk of cardiovascular disease because these smaller LDL particles that exceed in the blood might infiltrate the arterial wall and therefore create the plaque of atheroma and therefore might be responsible for acute heart attack. What might be also different in these conditions is that lifestyle is key for both conditions, but the diet is really, really important and fundamental for because it has been almost like the only treatment for FCS, whereas patients with HoFH might be limited in executing normal physical activities when complications of the heart might be a bit too severe. What is common then among these conditions? Well, first of all, the frequency. We are talking about very rare disease, so there is no better date to talk about this today. We are still facing two genetic disease that involve a lifelong journey, meaning that it's a condition that starts at birth and for which an early management is fundamental to avoid and to prevent the risk of complications. And the problem is that being very rare diseases, we are often facing misdiagnosis or a very significant delay in the diagnosis of both conditions. So this is something that is quite crucial because often the diagnosis starts after a complication already appeared, like a pancreatitis or a cardiovascular disease. Lifestyle, as I was saying, is crucial, although there are some differences in the two conditions, but lifestyle is definitely something that is important to encourage in both conditions. And due to the rare and the genetic nature of these conditions, of course, they have also in common the psychological burden that might be associated to the fact that sometimes, due to the misdiagnosis, we might think that it's our fault because we have been eating too much fat, when it's actually not the case, because there is a genetic defect underlying. There might be some fear of attending public events, and the confrontation with other people might be sometimes a significant burden, but I'm not here the best one to talk about this. You will have much more significant and important witnesses in this. And the other common trait about the two diseases is the therapeutical innovation. We are facing a real revolution in both conditions, which means that we are really in a new era where, compared to 10 years ago, we would have not imagined to get to a point where we can indeed control both diseases and potentially reduce the risk of complications associated to both diseases, and so the life trajectory of both conditions. This is just one last slide to show you how the evolution of treatments with new technologies of treatment has been associated with significant development of novel drugs. You see highlighted in red the first two on the right, on the left, like lumitapide and devinacumab, are two novel drugs for HoFH. And on the other side, we have some ApoC3 inhibitors that are used for FCS, which might be significantly changing the life trajectory of these disease. So I will just stop here. I will be happy to contribute to the discussion, and I leave the floor to the FH Europe ambassadors. I thank you very much for your attention.
Thank you very much for all the amazing preparation of your slides and explaining in the shortcut, let's say, because there's so much more, and it's not just the topic more than we can imagine, but there's so much more that we all need to learn about our community and the rare lipids disorders. I would like to get to the first segment of questions, and I would love to start with our patient ambassador for FCS, and not just ambassador, not just patient ambassador, but also a father. Finn, I would like to ask you a question. Can you share your journey to FCS diagnosis? What were some of the challenges receiving the diagnosis?
Hi, everyone. So I have three boys. The youngest of whom, who's now 18, was born in 2006. The other two boys had been well until this point, but when the youngest boy was 3 months old, he became quite ill. He started to reject feeds, vomit feeds. He was being breastfed, and then eventually one weekend he vomited all his feeds, and we took him to the local hospital. That was quite a difficult part of the journey, because first of all, he became really quite unwell. He was kind of unresponsive and floppy, and we were very scared. And we were even more scared when the healthcare professionals drew his blood. They kind of looked as scared as we were, because I think they didn't really know what they were looking at, because they had this sort of very thick, sort of milky pink blood. So it's always scary seeing medical professionals not knowing what's going on. They sort of couldn't wait to get rid of him, to be honest with you, at the local hospital. They got a drip into him and got him hydrated enough so that he was stable, and then they blue lighted us to a bigger hospital in the middle of London, Chelsea and Westminster Hospital, and he was to spend the next 5 weeks there while they tried to work out, lots and lots of different specialists looking at him, trying to work out what the issue was. One of the things that became clear was that whenever they tried to reintroduce breast milk through his nasogastric tube, he became unwell again, became more unwell. And eventually, towards the end of his time there, they suggested this diagnosis of what they called lipoprotein lipase deficiency, which I now understand is one of the sort of conditions which comes under the FCS tag, so to speak. Then because this was an autosomal recessive condition, therefore genetically each of our children had a 1 in 4 chance of having the condition. The other 2 boys had to be tested. And one of my clearest memories of that time was having Devon, who was the middle boy, who was 6 at the time and had been perfectly well. When they drew his blood, he was sat on my knee, and I didn't need to get the diagnosis. I could see straight away. I'd seen blood like that before from Carlo when he was very unwell, and I could see that it was very abnormal. Whereas with Cavan, who was 10 at the time, I could see that his blood looked like I expected blood to look, so to speak. So once that had happened, Chelsea and Westminster were fantastic. So the big hospital was fantastic. And we were then transferred over to the care of Great Ormond Street. And they were brilliant as well. But that first part of the journey, when you're in fear of your child dying and people clearly don't know what's going on, that was quite a scary moment, I have to say. Not one that, one that affected us quite a lot.
Thank you, Finn. Thank you for sharing that personal part of your journey. Marwa Sadiq, our HoFH patient ambassador, I would like to ask you how your diagnosis of HoFH was made and how early you have received it.
Hi, everyone. Thank you, Maya. So I was diagnosed age 3. It wasn't easy to diagnose me. I had xanthomas on my eyelids, and my mom noticed it. So she went to my dad, who was an eye doctor, or he still is an eye doctor, and she assumed it's something to do with the eyes. He looked at it, he had no idea, and he just assumed it was allergy. So we saw a doctor, and he goes, no, it's not allergy. Then we went to a dermatologist to figure out what it was. Again, they didn't know what it was, until someone advised us to see this certain dermatologist who is German, and they did a blood test. My results came back sky high, and they said most probably she's got high cholesterol. Then we went to Great Ormond Street, and the diagnosis was done in Great Ormond Street. They checked my parents. They both were carrier of, they're both heterozygous, and I was the one diagnosed with HoFH. So yeah, the treatment started straight away at the age of 3. I was put on Questran, but it took several doctors to get to that point.
Thank you, Marwa. Now I would like to ask Helga Davidsson, our FCS patient ambassador. Helga, did you face any misdiagnosis or delays in your diagnostic journey?
Hi everyone. As a child, I vomited a lot, and when that was investigated, they came back and said I had a nervous stomach. I also had a lot of tummy ache, and diarrhea, and that basically the tummy aches were put down to me trying to avoid going to school. But as I progressed into adulthood, the pancreatic attacks, they suggested that maybe I could possibly be an alcoholic. But so for over 10 years, I have documented elevated triglycerides. There was no viable reason why. The doctors, I don't think, fully understood either what was going on. I did respond well to a low-fat diet and regular exercise, which they advised me to do. That always resulted in me getting the reduction in the triglycerides, but they were always still higher than the normal values should be. It was around about, I think, the 12-year mark, after attending lipid clinics, that I had a very severe acute pancreatic attack. It actually nearly killed me. And several doctors later, my current lipid consultant decided to genetically test me, and that was when I finally got my diagnosis of FCS. So it was a very long journey for me.
Thank you, Helga. As we hear, there are some overlapping moments and some are completely different in the diagnostic journey. And speaking of that, Maria Nassif, our HoFH patient ambassador, listening to our previous experts, because I love to call you experts, because you are. From your perspective, how does the diagnostic journey of a HoFH compare to what you've heard about FCS?
Hello, everyone. First of all, thank you for having me in this webinar. In my point of view, my diagnosis of HoFH was really, I can say, really smooth. I had exanthemas at the age of 3 years old, and we knew that my father had high cholesterol, so I knew right away that I have some disease which is attached to high cholesterol. That's how HoFH can 90% be easy to be diagnosed at young age, and that's the difference that I saw with FCS, diagnosis of FCS, where the symptoms are more, I can say, similar with other diseases. When we talk about vomiting or pancreatitis, we can't know right away it's specific to FCS. And from what I have heard, that all of the patients have very, I can say, not early diagnosis comparing to HoFH diagnosis.
Thank you for your perspective. I would like to move to the next question round, and starting with Finian again. Fin, as a father, a caregiver of a child living with FCS, how has this experience affected your mental health?
Thank you. Well, I think sort of the initial period, we just were kind of living in fear because we he was so unwell, Carlo was so unwell that we weren't sure whether he was going to live, to be honest with you. And that obviously is just, you're kind of in terror, and that's a day-to-day thing. And also when you're in hospital with a child, we were taking turns to sleep with him and trying to keep normal life and work going with the other two boys, which is quite difficult. Once Carlo came home and we had the diagnosis, obviously we were trying to concentrate on being positive, but I think underneath, I suppose speak for myself, but probably also my wife, we felt a certain sense of sorrow and kind of a sense of loss that their lives would never be, if in inverted commas, normal. And that's always difficult, particularly for children, not to be seen as normal amongst their peers. One thing I will say is that when Devon, our middle child, became sort of showed signs of some mental health issues, he was immediately offered psychological support by Great Ormond Street Hospital, which is brilliant. And I'm not sure this happens enough. But of course, that isn't offered to caregivers. If you feel that you need that, you need to seek that out yourself. I will say that if in any of these situations where you're dealing with rare diseases and caregiving for someone with a rare disease and you're finding it overwhelming, you will need to seek that help yourself probably through your general practitioner. I did go through a period of depression, but I think in a lot of ways, having to sort of positively engage with the condition and having to think about, their diet every day and keeping them interested in exercise and so on and so forth was actually a positive way to get myself out of that depression. So it definitely had an effect. Those sorts of life events will always have an effect, but I kind of feel like to some extent, maybe we've come out a bit stronger at the end of it.
Thank you, Finian. Marwa, how do you manage the emotional aspects of the condition you're living with?
It's not easy. When I was much younger, when I was a child, I think I just got on with it. You've got xanthomas, pretend it's makeup. You've got a massive fistula on your arms that looks like a golf ball. Yeah, it's my superpower. But I think as an adult, I've realized that I suppressed a lot of emotions when I was a child, and I just, got on with it and be strong. Definitely has its ups and downs. As a parent now to two children, I know how difficult it was. I didn't realize it when I was young because my parents tried to protect me as much as possible from being bullied, or, I did everything. I played tennis, I swam, I was very active. I didn't know anything else but my diagnosis, and I thought that's normal life. As a grown up now, and I think COVID played a big part when I had to shield, I thought, oh, okay, I am a bit different. There is something that could stop me from being, normal. So it's a day-to-day struggle. There are good days where you think I am better than someone else. I've got great support group. I've got my family. I've got my husband, my children. But there are days where you struggle with the diagnosis and you think, oh, I wish I could do this. But so yeah, it's a journey, and I think definitely having the right, support group is definitely an advantage. People who love you and care for you. Just my diagnosis doesn't define who I am, and that's what I have to remember.
Thank you, Marwa. That's really powerful. Helga, were there specific moments that you felt that FCS felt particularly emotionally tough?
Thank you. Living with FCS is a daily challenge and tough most times that you have to make choices when eating out for food. It can get quite emotional. Before the diagnosis, I was also an emotional eater, which again, from the restrictive diet that I now have to follow, is a big challenge to overcome, and also to find other emotional crutches to rely on and step away from food in that sense. But most of the specific emotional challenges do revolve around food and the isolation that it causes socially. And it's also the frustration that it can cause, because when you're invited out for meals with friends, they don't understand that you have to be so restrictive in your diet, and often there is nothing available on the menu that you can eat. So in order to having to keep on repeating yourself time and time and time again, you end up, you isolate yourself, which does affect your mental health and your emotions, because it's just the burden of food within this condition can be so overwhelming.
Thank you, Helga. That's even difficult for me to hear, and encouraging and empowering to find out that all of you are finding solutions for that. And Maria, did you have any strategies? Do you have them at the moment? Strategies that have helped you to go through the difficult moment living with HoFH?
I'll be honest, the HoFH journey is quite scary, it's stressful, and it's depressive sometimes, especially that we live in anxiety, in fear for having heart attack or stroke, and depressive because sometimes there are activities that we used to do as young people, but now we can't because of cardiovascular diseases. So I end up have two choices in my life: either stay negative and in depression and anxiety, or just accept my disease. And that's what I did. I have said, okay, it is what it is. In the end of the day, everyone has a disease they're fighting that we don't know about. So, and I feel myself lucky that in these days, in our era, we have medicines, we have treatments, we have new medicines also on rise and on research, ongoing research. So I'm accepting my disease, I'm living with it, denying having a disease, and fighting the fact that I have HoFH didn't get me anywhere, and it hurt me even more. So yeah, I'm just listening to my doctors, what they're telling me to do. I'm going through a healthy lifestyle, taking my medicine, do the apheresis, and I'm alive. I'm healthy, thanks to that. And I want to add that by joining FH Europe Foundation has helped me also to navigate the negativity that I have with having HoFH into positivity by helping and raising other HoFH and other rare disease and other dyslipidemia diseases, help patients like us also to manage these diseases.
Yeah, that's something really important that we would like to take as one of the key information from what you've said, because that's what we work for, that's what we live for, that's our passion, to try to change the reality and try to support as much as is possible. Going to the question 3 theme, what dietary and what dietary lifestyle restrictions have you had to implement in your family's routine to manage the condition?
Thanks. Well, it's turns into a bit of a balancing act, really, because obviously we're a family of 5, and 2 of us have FCS and 3 of us don't. And I think there's probably a bit of a misunderstanding generally amongst people that they think that people with FCS will be incredibly healthy because they eat a very low-fat diet. And that's obviously, they fail to understand the nature of the fact that there are essential fats, and that in actual fact, not having those essential fats might be problematic and might be difficult. So the 2 boys with the condition have supplements and so on and so forth, which are designed to help with some of those vitamin deficiencies, which are fat soluble vitamins. We have to prepare separate menus. In effect, that's the way that we've done it, because otherwise we would be unhealthy because we wouldn't be getting the fats or the supplements, or the other way around, they would be unhealthy because they'd be eating too much fat. So generally speaking, 2 separate sort of just preparing separate meals for everyone. We're lucky that the boys are prescribed MCT oil, which is an oil that we can use, which doesn't have the long chain fats that go into the bloodstream, which cause the problems. So we can. I found it quite exciting actually to come up with recipes. I've always enjoyed cooking, to come up with tasty low-fat recipes. Also to try and keep food to be one of life's pleasures, because I think one of the dangers for people with FCS is that food becomes almost the enemy, and you're fighting it all the time, and that's particularly difficult. Holidays, going out with any social events, school trips, if we were talking about caring for school-age children, are really, really difficult, and really difficult for the patient, really difficult for the carer. So it can feel like a battle, and I kind of wanted to make food feel positive to them and teach them to cook themselves and to enjoy that, because there's still lots of things you can eat. One of the real difficulties I've found was because they couldn't have most of the treats that other children had. They couldn't have fried food, they couldn't have chocolate, they couldn't have all these lovely things that people, particularly kids, enjoy. It was too easy to let them eat too much sugar, which again could be problematic in terms of the potential for diabetes, type 2 diabetes, etc. But if you're not letting them have any of the other things, and you then don't let them have the boiled sweet, which is mainly sugar, you feel like an ogre. So that was another part of the balancing act. I would say it is a balancing act, and trying to keep food as something to enjoy is very difficult.
That's a great point, Finn. And I'm sure maybe one day you're going to be the author of a new cooking book for our FCS community, which could be actually good. Marwa, how does HoFH affect your daily activities?
again, I think what Helga mentioned about, for example, going out to restaurants, socializing with friends is not easy because I have to look at the menu before. Sometimes I was called, oh, you're being difficult. Why can't you choose a restaurant? And you have close friends that understand, but then you've got extended friends that don't know. You've just got, high cholesterol. I have high cholesterol, and it's having to explain, yes, I do have high cholesterol, but it's not like yours. Mine is 1 in 300,000. And the problem, it's a nice thing and a bad thing. I always say I look normal. There is no physical symptoms to say, hey, I have a special condition. I can't do X, Y, and Z. Oh, you're so slim. You look so healthy. It's not that. It's an invisible condition, but the consequences of not looking after myself could be fatal. So it's just trying to find the right food, trying to exercise enough, but not exercise too much because it's a risk if you exercise, too hard. It's not good for your heart. So just finding the right balance is a bit, I wouldn't say difficult, just, tricky a little bit. Especially now when I have kids, like when I've got the girls and we're cooking a meal, they are both heterozygous. So they do have my gene, but they're not homozygous, which is, slightly better. But again, they eat what I eat, which is quite nice. So it's a low-fat diet. But recently I started a new medication and I had to relearn that, I before used to be able to eat good fat. Now it's fat generally you can't have. So it's a learning process every day, but yeah, challenging, but not as bad as before. As Maria mentioned, we're quite lucky. There's new medications coming out, new therapies. I've said before, I can dare to grow old a little bit now, with the diagnosis and with the results that I'm getting from the treatments are amazing. So yeah.
Thank you so much, Marwa. Helga, what are some lifestyle habits you've had to adapt due to FCS?
The biggest lifestyle change has got to be the diet. Before my diagnosis, I was advised to eat a low-fat diet, but was never advised just how low I had to eat. Now, with the diagnosis of FCS, I understand better the importance of keeping a very low-fat diet, between 10 to 20 grams of fat daily. It is extreme, but it's what keeps me as healthy as I can be. Together with the habit of having daily exercise, that's just become part of my nature now. I do a 30 to 40-minute dog walk twice a day. And also to help me with my mental health, I also do some yoga to just relax and take my head to a different space. And the other thing that hasn't been mentioned as well with the triglycerides, alcohol can raise them quite badly. And I also have decided to abstain totally from alcohol due to that. So I'm just trying to change my habits and my lifestyle in a way that the odds are stacked with me, not against.
Thank you, Helga, for your answer. Maria, what advice would you give to someone newly diagnosed with HoFH regarding the lifestyle changes, lifestyle activities?
First advice I would give someone newly diagnosed with HoFH is listen first your doctor's instructions, and second, don't be scared to know more about HoFH, know more about your body, like do tests, do some images, echoes, and everything you need to know your body status, I can say, to know if you have cardiovascular diseases, if you have any atherosclerosis, know your level, know everything. Don't be scared, because if you don't know, you can't heal yourself, and the doctors can't help you stay healthy. So I think it's very important to be aware of everything you need to know about HoFH. Second of all, I would say it is important is I said ask about what you can and you can't do also with the doctors, like I know internet is very easy, it's very reachable, but doctors are more professionals about this. So ask them what kind of activities you can have. Like I know I can do yoga and Pilates, but not weightlifting, for example. I had discussion with my doctors about pregnancies, being a woman. It's good also to know which medicines to take and how can they affect our bodies. Like, some of them can affect the liver. So I recommend to ask all of these questions. Don't stay in the dark.
Brilliant. Thank you, Maria. Last expert question I have from my side is, Finn, what has your experience been with accessing care for FCS?
Thanks. Well, I feel like in lots of ways we've been very fortunate. I feel like we've won what's sometimes referred to as a postcode lottery as far as our journey with accessing care for the boys FCS. We live in London. They've been cared for by Great Ormond Street, who have been fantastic. Apart from that initial sort of bit with the local hospital, their care has been brilliant. They were under the care of the metabolic clinic. Every appointment they had a consultant, they had blood tests, and they also had a dietitian appointment at every appointment. So we were getting advice all the way along the line. When Devon started to show signs of struggling with his mental health, he was offered counselling. I often have heard tales, particularly as I've engaged more and more with the community, rare disease community and the FCS community, of people who are diagnosed much later in life, of people presenting with pancreatitis, of then being accused of being alcoholics. This obviously doesn't happen with a 3-month-old baby or even a 6-month-old child. Apart from we had the occasional issue with our GPs not wanting to issue the prescriptions that their consultant at Great Ormond Street had given us, and saying they needed to come in for a review of their prescriptions, when it wasn't them that had prescribed these things in the first place. That's all been pretty good. And then now the two boys who have the condition are 24 and 18 respectively, and they've had a fairly seamless transition as well from childhood services to adult services, which again is a really important time. I think it's difficult for carers because you're kind of having to let go, and difficult for them because suddenly they have all the responsibilities for themselves. But that's also been pretty good. And I'd say, as my concern is that this globally, this is not the case a lot of the time, and that worries me.
That's really important what you've said, and I think we all need to talk about it and bring on to all difficulties that comes along with the conditions and care access. Marwa, how accessible are treatments and support system for HoFH patients from your perspective?
I would say I've been lucky. I was very lucky to be around the right hospitals, the right GP, right doctors. So speaking of my experience being in London, as Finn said, I've got brilliant care in the hospital. I have my annual echo done, checking my carotids, having medication review every now and then, trying new therapies as well. So I've been very, very lucky. I know a lot of my fellow patients who are in different countries, they struggled with that. And it's really sad to see that some people in other places that cannot get the right medication, even though they exist and they're there, but just the system doesn't work. I've always spoke about early diagnosis, being on treatment quite young, starting dialysis when I was 9 years old. Proudly say I am a lipids patient, not a cardiac patient. And that's only because I was under the right team. My doctor and my nurses, we've got a very open conversation about what's the next step, whether we should increase the dosage of certain medication, whether we should introduce a new medication or new therapies. So it's not a one-way relationship of the doctor saying this is what you're going to take and this is the way it is. It's actually would you like to try that? How is that working for you? What is the side effects? Are you happy with those side effects? So I think having an open conversation with the medical team that is looking after you is quite important. So within the UK, yes, we're very lucky. Saying that, I did struggle with one of the GPs when I was much younger, who refused to provide funding for the apheresis. And when we spoke to the consultant in the hospital, they said that's quite silly of them not to do it. So you need it. It's to save your life. So we were advised to move GPs, and then the GP that I've been with over 20 years now, they were brilliant. They've never questioned anything. They've always provided the care I needed. If I just say I've got, a bit of tight chest, they straight away go see the doctor. We'll get tests done. So being under the right team and having that honest, open conversation with the patient, because as you mentioned, we've lived this with this disease as long as I remember. I was 3, so I know pretty much a lot of things about it. So yeah, I'm one of the lucky ones where I live in a country where there's a lot of new medications coming out and therapies that I'm involved in taking decisions whether I want to try them and if I should try them, with obviously the consultants and the experts in it.
Thank you, Mara. Helga, we've chatted before and about different areas, more and less difficult. But the question is, what barriers have you faced in receiving appropriate care for FCS?
I would say that the biggest barrier was getting information about FCS. A lot of the healthcare providers didn't have appropriate education about FCS or rare diseases in general. And they weren't able to relay any information to me that was on the basis of how I could take care of myself. Because that information was quite thin on the ground. But that was where patient organisations, they tended to fill the gap for me. When I was diagnosed with FCS, the only viable treatment was lifestyle changes. And for many, that is still the only viable treatment. But the patient organisations, connected me to other people living with the same conditions that had more experience of it. And it also made me feel supported, like I wasn't the only one. And quite often I took the information that I got from these groups back to the consultant in clinic and educated them. But there is new therapies that are now available, but there's still barriers to receive those treatments. I'm based in Scotland, where there is no approved treatments for FCS. But if I cross the border into England, there is available treatments for FCS. So for now, I need to stick to my diet and exercise. And I suppose that's just down to, as Finn said, the postcode lottery.
Thank you so much, Helga. Maria, the last question for you, ending a session, what improvement would you like to see in access to HoFH care?
From my experience, I feel myself lucky to, as I said, I have access to all the treatments that I need with apheresis, with the new medicines. Some patients don't have, and I'm talking about patients living in both third and first world countries. There are some countries, some leaders who just don't want to help their citizens stay alive, and I think that's sad. It makes me feel guilty at the same time. When I was young, I dreamed when I get older, we'll have like hologram calls and flying cars, but instead we are fighting for people to stay alive. And I think this should change. Everyone should have the right treatment, the treatment that they need, the efficient treatment for them. And that's, I make it my life mission, but I think it's cruel, it's sad. And that's why I have reached out and joined FHR Foundation 1 year ago.
Thank you for your answer. Okay, now what I believe everybody will be looking for, we can come to Q&A session. So we have a question. There is a question from, are there any overlapping symptoms between HoFH and FCS that can cause misdiagnosis? Could I ask this question our medical expert, Dr. Gallo?
Thank you, Maya. So I would say that the symptoms, as it has been also described by the speakers, are not really the same. There are more specific gastrointestinal symptoms for FCS, whereas HoFH is more of a silent disease, and symptoms might appear when there is some cardiovascular risk that is about to give signs. So the spectrum of the symptoms is quite different, and this does not lead to misdiagnosis, meaning that we might diagnose one disease for the other.
Thank you so much for the answer. And I have a question here from Marina Kuchel, if I pronounce it right. This is to the entire group, to the HoFH patients and to Finian. What advantages or disadvantages do you see of having had the diagnosis at the very young age? And to Helga, how her take on the disease is affected by the fact that she was diagnosed later in life. Can we start with Finn? Yeah.
Sure. Yes. Well, there are a couple of advantages being diagnosed early. Is obviously, particularly with FCS, I can't speak so much of HoFH because I don't understand the condition as well, but there's much less danger of causing yourself long-term harm. The earlier you're diagnosed, the earlier you can adjust your diet and your lifestyle, the easier. And the other thing I would say, just from the difference between a 3-month-old and a 6-year-old being diagnosed, the 6-year-old had got used to eating things that he fell in love with, which he could then no longer eat. And that's a much more difficult journey. And I'm sure Helga will attest to that, to have found things you love, then to lose them, than to have never had them in the first place. So that would be my sort of quick answer to that.
Thank you. Thank you, Finn. Maybe Helga, so we're going to keep with FCS first and HoFH after. Helga, would you like to answer your part of the question?
Yeah, I was diagnosed at 48. And again, I had all the lovely rich fatty foods and acquired a taste for them. That had to be edited right out my diet. But the other thing, because of the pancreatic attacks, my pancreas is now permanently damaged, and I have to take external enzymes in order for me to be able to diagnose my food. I think if I'd have had an earlier diagnosis, that would have been avoided. So it's added to the disease, not getting that early diagnosis.
Thank you, Helga. What about our HoFH ladies? How do you feel about it, Maria? How do you feel that the time of the diagnosis, how it affected the timing? Being diagnosed
talking about
early.
HoFH, being diagnosed early, it means we have less of atherosclerosis, so less of fat attached to our arteries. I'm going to speak a bit of myself because I didn't have the right treatment for me from very young age. So I still had some fatty deposit on my arteries, and I ended up having atherosclerosis and then open heart surgery as young as 24 years old. So I was diagnosed early, but I didn't have the right treatment. So both are important, having the early treatment and the right treatment for the HoFH patients.
Thank you. Marwa, now I'm going to ask you questions. We're going to hop to another question that is directed directed to you. Can you speak about your experience with pregnancy?
Yes.
From when you've decided to have children to the care that you received during and after the pregnancy?
So I was told I can't have children when I was diagnosed. And I remember one of the first things that I rebelled against is, why can I not have children, you know? And one of the consultants said, no, there's no way. Then when I met my partner and I spoke to another doctor, they said it's possible, but you have to go through the right journey. We tested my partner to make sure he doesn't have the gene. Because I didn't want to have another homozygous baby. I know that my kids will be heterozygous. So the first step was to test him. He was all clear. When we thought it's the right time, I spoke to my consultant, my lipid consultant, and they said, okay, let's refer you to gynae, obs and gynae. And I saw the professor there. She goes, did echoes, we did blood tests, we did stress tests on my heart. And we had to go through me stopping my medication for 3 months to make sure everything is out of my system. We increased apheresis from once every 2 weeks to twice a week during that time because I was not on any medication. I stopped everything. Only Costran came back into the picture. And fell pregnant. During the pregnancy, I was seen by the high-risk doctor for obs and gynae. I was followed up, I think, about every other week. I did echoes through the pregnancy. And when it came to the idea of giving birth, whether it's natural birth or C-section, they tested me again and they said, no, you're absolutely fine. You can have natural birth. Birth both girls naturally. Took 18 hours of 36 hours, but I got there. Thankfully, they were both fine. I came out just fine. There were no complications in terms of cardiac problems. It was a hard journey because I was almost 9 months pregnant and I was doing apheresis twice a week, almost 2 hours or 3 hours every session. So it wasn't easy. It wasn't a normal pregnancy, as you'd say, but definitely worth it. But I'd say for anybody who wants to take that step, first step is to make sure your heart is okay, your arteries can take it, because any pregnancy is a risk on the mom, increases the cholesterol anyway for any normal, healthy women, let alone someone like me. So yeah, that's quite just running through the pregnancies and how it was. But thankfully, there were absolutely no complications in terms of cardiac problems.
Thank you so much, Marwa. We are running out of time. There's just a very last question that we can take. The rest of the questions will be answered in follow-up emails, so don't worry. I think we're gonna direct it to our medical expert. Does doctor has experience with FCS and ADHD medications, and do they affect it? I guess, do the medication affect FCS?
So some of
condition?
the treatments, I do not have specific experience because I do not have FCS patients that need these treatments, but some therapeutical classes might lead to an increase in triglycerides. So it's a matter of risk-benefit ratio, and we need to find a balance between the risk of the side effects and how this can impact triglycerides. But some other treatments do not have any impact on triglycerides levels, so we might choose for the best option in order to limit these metabolic side effects.
Okay, thank you so much. As I said, unfortunately, we are running out of time and coming to the end of our webinar. I want to extend a heartfelt thank you to all our participants, speakers, Professor Gallo, our FH Europe Foundation ambassadors, for you made this session insightful and engaging, and thank you so much from the bottom of my heart. Thank you for sharing part of something that it's so private and so intimate, a part of your life that it's having ups and downs, and it's difficult. Sharing the information of your life makes our knowledge expanding And for that reason, we can do more. We can try to change things that they need to be changed. For that reason, I'm thanking you very much. As I mentioned, any answered questions, don't worry, we will address them in a follow-up email. And we will truly value your feedback. So please take a moment to fill out our feedback survey. That it will improve our future webinars. It was my first webinar for FH Europe Foundation, and I had, as Finn said, healthy nerves. So thank you, Gabe, for joining us. We look forward to seeing you in the future at the FH Europe events. And speaking of which, I already would love to invite you for our upcoming webinar about LP little a. It's coming out LP little a Awareness Day on the 24th of March. The webinar will take place on 31st of March, and you can already assign to it. So thank you so much for today. Thank you all. It's been a pleasure to be here with you on this very rare disease day. So let's hope that our future will be changed with small steps or the bigger one, with all support that we give each other. Thank you so much.